or if the link doesn't work, they always email me right away for whatever reason. The link doesn't copy and paste. Links are funny sometimes where there's multiple links in the same session. Either my clipboard doesn't do it or I fail to just confirm that link works. I think sometimes admins will say my end and it may not. So if you didn't get the case on there, you get the SI joint article, sorry. But here's the case, and I'll be happy to send it out to you afterward. Take a second and read this case. And again, tell me what your thoughts are on the differentials, if you have any other differentials.
Yeah.
To do that, Chris, eventually need to unmute. Take a peek. Take a look at this case. Anyone else wants to pop in at here or talk to me what other differentials, just by reading the case without going further, would you have this differential?
Oh, you're playing on the 9th. It's on Saturday.
All right, Chris, what do you have? Any other differentials you put in here? Just reading the case without looking at what you have below.
I can't think of any offhand. The first one I was thinking was the either fracture, or some sort of bone bruise.
Anyone else? Differential came to mind reading this. Or Chris, why not tendinopathy?
Yeah, I was talking.
Because it started after the race. There's kind of that race seems like it almost explains it a little bit.
Chris, tell me through the active passive resistant. What have you learned when you look at the active passive resistant testing data there?
So it doesn't. Sounds like the range of motion is normal. Pain with elbow extension would be more triceps.
Steps going over court. Now, I think you can do steps.
Oh.
No. Steps.
So we have one pain pattern.
So,
One pain, right?
yeah. So only pain with active elbow extension and overpressure. So it's not, doesn't really.
They're coming in and out, or I'm coming in and out.
I guess it seems to take out muscular sort of pathology.
Yeah, the answer is going to be helpful. That's why, again, as you get better, as you get into the courts, and it's going to emphasize that really a lot of information we're going to get is in the end fields. This individual, for instance, we have pain with active elbow extension and, then with overpressure into the joint. So it's not so much looking at it with resistance tests.
Yeah.
So we have no pain with elbow extension resistance, but we have pain with the overpressure in that position. That's kind of where, look at that where, dermatitis can still be in play there, but, we can be looking at basically the joint biomechanical dysfunction. So, with this right here, which ones kind of eliminate all the around fracture, again, the resistance test too kind of, again, okay, you can always think of tendinopathy somewhere in here as well. Tricep tendinopathy because it's location, but with lack of pain in the resistance test, that kind of drops lower in differentials. No pain with supination, pronation, that's probably going to give some information if we're looking at, potentially or at the, proximal radio ulnar joint as well. Patrick, talk to me about the stability test. What do you gain from the stability test? What do you think the hypothesis is?
I thought it was bootier. I thought too much.
Yeah, so stress tests, it looks like it tells us that there's no significant sprain to any of the ligamentous structures. And it looks like with the other negative tests that it kind of rules out maybe fracture.
Yeah.
Yeah, and this is kind of where again, superior radial ulnar joint kind of, cut out and eliminates that as far as there with the shearing test, negative, cornoid ligament and negative UCL, RCL chest. Well, that's where a lot of this information, what you have to do with this, some of it now becomes advised correct. We're like, okay, it's this joint. Knowing that I have negative tests are always super valuable. It really then starts to whittle down and clear up, okay, is it strengthening my hypothesis or weakening my hypothesis? And again, as they put in there, the idea that, okay, my ligament and stress tests are intact. Like Eric puts in there that, okay, now I'm not thinking that, okay, if it becomes a manipulable lesion in there, that would strengthen me as far as that. We can kind of get into that a little bit more too, because many times, you can have an unstable joint and something that's getting subluxed. That's the reason why it's subluxed.
Oh, yeah.
Quadrant tests. Teresa, talk to me about quadrant tests. Love them? You hate them? Learning to love them?
Well, exposure to this program has really introduced me to quadrant testing. Beforehand, it was not a part of my practice, so I think it's a learn to love. I'm learning to see some of that benefit of combining motions, but then I kind of have a hard time stringing together what it means for me or what to do with it next. So that's where the hate part comes in, that it gives me information, but I'm like, great, what do I do with this information now? So like you indicating here that there's some decreased movement in some of their quadrants, and you have written on the right-hand side that indicates an issue with the ulnohumeral joint. I'm not sure I understand why.
So it has to do with the ovoid of motions, Teresa. So the flexion, supination, and abduction quadrant has a wider ovoid because of the saddle shape of the ulnohumeral joint. It's the same thing with pronation, extension, and abduction. It's a wider ovoid, right? So when we look at the radiohumeral joint or the radial head in general, I always say that we can't necessarily distinguish between a superior radioulnar joint issue and a radiohumeral issue with quadrant testing, because it tends to be if there's any effect on the radial head itself, whether it's a pronation supination issue from an anterior medial or posterior lateral glide issue at the superior radioulnar joint, it'll have the same effect with these the opposite quadrants. So flexion, pronation, and adduction will be affected, and then extension, supination, and adduction will be affected. So it's just a matter of kind of recognizing that all of the quadrants that involve abduction, abduction, are ulnohumeral issues. All of the quadrants that involve adduction, adduction, are radial head issues. And at that point, it's just a matter of figuring out what the issue is. Is it an abducted ulna? Is it a extension limitation of ulnohumeral movement? Is it a flexion limitation of ulnohumeral movement? If it's more of a adduction quadrant limitation, is it superior radioulnar joint or is it radiohumeral joint, flexion, extension, pronation, supination? It's just a matter of doing the mobility tests at that point to figure out what it is. Most quadrants aren't going to be that specific. If we do quadrants for like the hip, it's not going to tell you specifically what the problem is. It's just going to give you an idea that there is a problem. But it's a nice test when being able to do the quadrants because it tells you almost specifically, hey, this is where you've got to look. So it is definitely beneficial to get used to them. If you don't quite understand, or you can't quite just remember right off the bat which quadrants are specific for each particular component, ulnohumeral versus radial head, then you just have to go through and do the mobility testing to figure out where the problem is. But it's easy. It does make it a little easier, obviously, if you remember which quadrants are problematic for each individual component, because then you can specifically just go to that component and check on it. Does that make sense?
Yeah, that does. Thank you. So, I mean, is it also fair to say though that would quadrant testing just also be testing the capsule of the joint itself as well?
It can, certainly. It depends on the end feel that you get at the end of range of motion. Quadrant testing in general, so if we think about it in the spine, right? So if we do an extension quadrant in the spine, it's ensuring that we get the articular structures, so the joints themselves, through their full excursion of motion. So it's the same thing here at the elbow, be the same thing at the hip. We're making sure that we're taking that joint through its full excursion. So if you get to a barrier, it just depends whether it's limited or not. It'll just depend on what tissue you're running into when you get to that barrier. So if you get all the way to the end and it feels like a capsular limitation or a capsular end feel, even if there's no limitation, then yeah, you'd be testing the capsule at that point. But in some cases, for instance, with abducted ulnas, if you go and you're doing this quadrant test here specifically in flexion, it's not going to feel very capsular. It's going to feel more pathomechanical. So it just depends
Okay.
on what structure it is that's limiting the movement if you have a limitation of movement. Otherwise, if there is
Okay.
no limitation,
That helps.
then you're probably good and you don't have to worry about the elbow.
You say if you're stronger with one, let's say you're stronger with your biomechanical, and best thing to do early on with the quadrants is to play them off of each other. Because many times you'll find that, okay, well, I find that, okay, this person has an abducted ulna. Okay, let me go ahead and do my quadrant and see where I feel it in the quadrant. So from a learning standpoint, hopeful sometimes, as you're doing this, play the quadrant off of the test. You have a positive quadrant, then you go into your specific testing. It's like, oh, okay, I picked it up in this quadrant where it felt a little bit off. Now I see it in the biomechanical test and kind of go back and forth between them. That's good. It's a good way to kind of cement in your mind that, when I'm seeing this quadrant as positive, I commonly find X. I think it's also helpful, as Eric said, if I'm finding this flexion, supination, abduction, extension, pronation, abduction, always positive. Okay, let me go look at the ulnohumeral joint as being it, and using that as kind of a grid of, okay, let me go down this pathway. But best thing to do is that early on learning this, play them off of each other. And that's where you'll kind of develop a sense of feel and like, okay, these things usually match up. Ariel, you're the mobility testing person, aren't you? You're feeling. Don't tell me I'm not. Talk to me about the
What was
mobility
that?
test. The mobility testing person, I can feel you were dying to get this one.
Sure, except I just like kind of started paying attention because I was with the patient, but go for it. What am I looking at?
So glance at the mobility tests on the screen here, and then look at the red letters, the red letters in the box on the side, and tell us how do those tests and the results of the tests on the left, how do those add up to the determination that we make on the right?
And everyone else, feel free to chime in on chat, throwing in some thoughts about a friend. Don't feel like you need to hang her out to dry.
So let's start here, Ariel. Let's look at the second one and the fourth.
Yeah.
So
All right, normal radial humeral glides, decreased right ulnar humeral lateral glide with pathomechanical end feel. Okay, combined with loss of the quadrant testing and the loss of the ulnar humeral lateral glide with pathomechanical end feel suggests an abducted ulna. So that was, and you're asking how did I get there?
yeah, how do we get to the conclusion on the right within the red letters there in that box from the information that we were given on those mobility tests on the left? How do those two things match up?
So it's the ulna is not sitting well in the joint, leading to the decreased right ulnar sorry, just not focusing very well.
Wasn't there a cluster of things for the abducted ulna? So like with her mobility testing, just in conjunction with all these other things, would really ultimately lead us to this conclusion?
Yeah, I mean, it says so right here, right? If we combine the quadrant test results, right? So loss of flexion, supination, abduction. And then we also look at the loss of extension, pronation, abduction. Those both suggest that the ulnohumeral joint, because they both have abduction involved, they both suggest that the ulnohumeral joint is involved, right? And then when we go to our mobility tests and we look at the fact, so the third bullet point down there, decreased ulnohumeral lateral glide. So a lateral glide of the ulna on the humerus with a pathomechanical end feel. That's our confirmation right there. I mean, the signs of the cluster, you know, where the pain is, quadrant testing being positive in the kind of orientation that it is, and then we find that abducted or that loss of lateral ulnohumeral glide. That is really pretty specific. That's very confirmatory for the idea that there is an abducted ulna. There's a few other things that you can look at here, but they come kind of further down under positional testing for things that go with the radius, limitations of wrist extension, things of that sort of nature. But those will tend to require some of those sequela to happen. The dysfunction of the radial head or of the radius itself as a whole will tend to affect those other things like, you know, pronation, supination, or wrist extension, et cetera. So those sort of things kind of come as a secondary problem. But you're just right. I mean, if you combine the quadrant testing with the loss of glide, then that tells us exactly all we need to know. And the only other things that we see on here under mobility tests is radial head joint glides are pretty normal. And with no pain. So that tends to suggest that the radius, you know, if there is some shunting, it hasn't become problematic yet from a mobility perspective.
Can we talk about, with an abducted ulna, what the correlation is with the scaphoid? I remember there being something about the scaphoid as well with this.
Yeah. So again, this is another sequela, right? This is something that comes after the fact. So if you're looking at the abduction of the ulna as the driving mechanism, this is the original dysfunction, right? So that comes about, that affects position of the elbow, right? So instead of being something where we have something straight like this, we end up with it kind of abducted in a position like that. What that will do is it will tend to compress the radius against the capitulum of the humerus, right? So the bottom of the humerus. That can create, number one, it could create irritation of the radiohumeral joint here. So they may feel it laterally, they may feel it anteriorly, they may feel it posteriorly, depending on, you know, where exactly the irritated tissue comes from. But the other thing that will do over time is it will start to push the radius toward the wrist. Right. And so we get this shunting of the radius toward the wrist. Now, as that happens, the radius now is going to be, we're going to have kind of what we call this radio-ulnar, what's the word I'm looking for? Variance, right? So this radio-ulnar variance. And so we end up with something like that, where the radius looks like it's further down the wrist than the ulna. That's going to cause a change in kind of orientation of the carpal bones, right? It has to. We're taking up space here with the distal end of the radius. So the carpal bones have to adapt to that sort of thing. So if I'm going into wrist extension, or if I'm a patient that has to put my hands in wrist extension for long periods of time, for instance, if I'm somebody that sits at a computer and does a lot of typing with my wrist cocked back like that, we have to make room. And so one of the major things that will happen is the scaphoid will press into the palm, basically to get out of the way, so that it'll allow more movements. Now that the scaphoid's out of the way, the rest of the carpal mass has a little more space to operate. So in those sort of situations, you'll have patients coming in with palmar wrist pain, maybe potentially base of the thumb pain, things of that sort of nature. You may end up with dorsal pain from the original compression against the distal end of the radius. So there's all kinds of different presentations that can kind of pop into the office as a result of that. But the overlying dysfunction that tends to happen to the scaphoid is it tends to press or sublux palmarly, in order to basically make more space for movement of the rest of the carpal mass. That makes sense?
Yes, that does. Thank you.
Mhm.
And I think an easy way sometimes if I move my hand around, take my elbow, almost taking the angle that you abduct your elbow, and watch how the wrist is going to, ulnarly deviate. The thumb is going to almost compress up. It almost like as I do it in that position, you'll see that glide and that translation. Similar to what they talk about too, if somebody's like typing and they're obese, they tend to put their arms out to the side of it and their wrist and their carpals kind of rotates, like we call it elbow pain, carpal tunnel. You'll see deviations. Just with yourself, you can just take your elbow and say, okay, as I move this around, the wrist automatically starts to deviate in that direction with a high carrying angle. And maybe genetically, if it's genetic, then you've kind of adapted to it. That tendency in a normal wrist, even on yourself, thumb does as you get into the patient and front line. Let's start with the manipulation a little bit here, because I think this manipulation, you're going to start off somewhat sloppy with. I think it's fairly normal. And the difficulty you're going to have probably is, finding the end feel, and, many times what you're going to do is you're going to find, okay, I do this, I get a lot of glenohumeral motion as you do your first technique. I think for many of you, you need to know that it's going to be okay that many times when you go to manipulate this the first time, probably going to be off your angle. You're going to need to flex or extend. You're going to need to adjust your pronation, supination, or to lock out your body position so that you create less internal, probably internal rotation shoulder as you do the manipulation. So when your first one you do it and it feels a little sloppy, what I recommend doing is knowing that, okay, your second one is probably going to be the one where you're going to be more efficient. And know that when your first one, it's okay if you're a little bit sloppy, set your gain and you'll get a sense of what you need to readjust. If you go to manipulate and you feel that the forearm is moving too much, okay, I need to adjust my supination pronation. I need to redefine that. If you do that and you go to thrust and okay, their shoulder internally rotates, you need to kind of fuss and fiddle a little bit, kind of get a sense of my end feel. When do I lock the shoulder out? And how much extension or body rotation do I need? So just know that with this one, it's very common. You come out of here and you'll come to the next class and it'll still feel sloppy, but don't feel like it's a one and done. If you're test it a little bit, play with it. If your first one's a little sloppy, readjust. Okay.
Yeah. Yeah, I always go back to what Gail told me once about what she calls building a barrier. So if you have a situation with like this abducted ulna manipulation, we talked about kind of 3 different methods to do that, where we're doing the kind of that osteokinematic whip version, which tends to be more effective because you can get higher velocity, and it's really more of this kind of running start sort of thing, but you also run into a little more risk to the structures of the lateral elbow. We talked about being very specific and getting right onto the little hook of the ulna here and trying to do a little thrust like that, much safer, but far less effective, just because it's harder to build up the proper acceleration to do that technique. So we did the one where we were kind of hooking the person's arm underneath our elbow and we're getting just like right on the joint line. And it's almost like we're just taking the whole joint line and trying to kind of close the medial side and gap the lateral side. And it's kind of that happy medium where it's more effective than the direct technique, but it's, safer than the osteokinematic kind of whip technique that we showed you. So the problem with it is that because of the position of the humerus, you can get a lot of flexibility and a lot of movement in the glenohumeral joint. So changing the variability of the flexion extension position of the elbow, the pronation, supination position of the forearm can help to tighten things up and build a barrier there. If you have the patient laying down and their arm is down at their side, essentially putting their shoulder in a kind of a least pack position, you may do better if you sit them up and now take the arm out in front of them, right? And then you can abduct the arm slightly. Those things will tighten up the shoulder joint, right? That builds a greater amount of tension through the glenohumeral joint. So it ends up tightening up the humerus, which then helps you build that barrier a little bit better. So changing positions of the patient, changing positions of the joint in question, of the various components of the joint, so pronation, supination, flexion, extension, etc., to try and build that barrier. Because what you really want to find is you want to find the most appropriate vector, right? I can do a thrust that goes in this direction. I can change my direction, go this way more. I can change my direction, go this way more. I can do this direction more. There's little changes because we're dealing with, it's not just 360 degrees, right? We're dealing with this in a three-dimensional model here with a human body. So there's 360 degrees in 360 degrees in every single direction, right? So I'm not doing the math. Dave, you can do the math for me while I'm talking. But the point is there's so many different little variations you can change on these vectors in order to build that barrier and find that appropriate end feel for where it's going to be the most effective. So it's little things like that you'll get used to doing almost subconsciously. You won't even think about you're doing it. You'll just start kind of moving your body, changing your position, change the position of their shoulder, change the position of their elbow, and eventually you'll just be like, there it is, and then whack, you'll hit it, and it'll just go like that. So you'll get used to doing that sort of stuff, but it takes time. It takes practice, and it takes kind of an awareness that you have to have when you're going through the process here of setting up these techniques. It won't be as fast as you won't get to that end point quite as fast early on when you're learning these things, but that's the point of learning something new. If it was really easy, every physical therapist would be able to do these things, right? This is what's going to separate you guys from everybody else when you're done with this stuff, is you'll know all these things and you'll just be able to rattle through them real quickly. And it'll be easy for you, hopefully. At least that's the plan.
I emphasize those of you who have OT in the clinic. This is mandatory on any of your shoulder. You want to go through the biomechanical scan quadrant at least. You need to kind of understand what the elbow and even the wrist is doing at that point. So again, I only see OT, so I never see these. You need to kind of understand these influences kind of moving up and down the chain. They'll be surprised if you find something like this because they're compensating for shoulder motion. It may be asymptomatic at that point, but you want to be looking at these things.
Yeah. And the other thing is if you have OTs in the clinic or hand therapists or anybody that specifically focuses on the wrist and the hand, they have somebody that comes in with, say dorsal wrist pain, and they can get somebody feeling better and they have them going through their typical routines, but it's just not carrying over, or it's like, oh, it's 75% better. We just can't seem to get over that hump. It's a good spot for you to, be able to kind of just step in and say, hey, you know what? Have you tried looking at the elbow as a potential driver for this issue? Maybe there's something there that's affecting the wrist. And that's why, you can't get that last 25%, or you can't quite get that last little bit corrected, or you can't maintain a good correction if there has been one, right? So those are little things. I mean, not to, tell you guys to go step on other practitioners' toes, but when you're working in the same clinic and the job is to get everybody onto some sort of self-management routine, nothing wrong with that little collaborative effort. So it's a good way to kind of be able to still be involved with wrists and elbows, etc., when you have an OT or a hand therapist and specific hand therapist in the clinic, is that you can still say, well, have you tried looking into this possibility? And if they say, no, I'm not sure what you're talking about, you can say, well, when they come in next time, let me know and I'll come take a quick look at it and I'll show you what I'm talking about. So it becomes more collaborative at that point, as opposed to you just saying like, well, I know what it is, stand aside sort of thing.
I have a question real quick about doing the abducted ulna manipulation. If you go back and like retest those quadrants that were painful before, will they typically be less painful? I just have a patient that I tried it on and I feel like it was a little sloppy. So I went back and retested like the flexion, supination, abduction quadrant, and it felt a little bit better, but I was just wondering like if it will be like completely pain-free after trying the manipulation.
It will depend on what structure was causing the pain. So in a situation like this patient here on the screen, where it's more that posterior impingement of the olecranon into the olecranon fossa, If you go into full extension, it's probably still going to be sore because the irritated tissue is more the actual joint surfaces, right? If, on the other hand, it's a situation where you're decompressing the radial head by fixing it, and then you go through that, it probably won't be painful, right? Because it's already moved, and now you're moving freely. So that probably won't be the case. If it's the joint capsule and you're still testing the quadrants are going to stress the joint capsule at the end range. You'll probably still have a pain response. What you're looking for in those situations when there remains a pain response at end range is you're looking for the improvement in range of motion. Okay, so the excursion of the movement has to be back to normal, or at least symmetrical to the other limb, right? So when you do that sort of thing and you say, okay, it might still be pain, and this you just tell the patient, might still be painful at some of these end ranges for a few days while the tissue calms down. But the fact that we've been able to restore the range of motion suggests that over the next few days, that pain should start to dissipate. That's usually the way I look at it. Is it will depend on what structure, what tissue it is within the elbow that's actually painful. Dave, you think you usually see that same sort of thing?
Yes, that's exactly what you see. I think like a pressure valve in some cases. Yeah, joint capsule, it's tendinopathy that's secondary to this, takes the pressure off of it. So many times you'll see that if it'll take away a little bit of the bite. If it's all of it, then it takes away all the pain. I've seen that where this has been primary, it's painful, you release it, they're all better. Other ones, it's like, okay, this is a large contributing factor. You see improved range of motion, reduction in symptoms, and then they're usually getting better after that. And his elbow gets significantly better after this. Whatever the knowledge is secondary to this.
So again, if you run into a situation where it's like, oh, it's definitely a little bit better, but the range of motion is where you'd expect it to be, then I'm happy. At that point, I'm just like, well, yeah, whatever the irritated tissue is, just needs some time to completely cool off and go through the stages of the healing process. Especially if it's a soft tissue injury, right? So if it's capsular and the capsule has been kind of progressively micro damaged, you get a little small micro trauma to this tissue over time. That tissue still has to go through the process of healing, right? It's got to go through the 3 stages, the granular phase and the substrate phase and the remodeling phase and all those sort of things. And that isn't something that happens immediately with a manipulation. Like we can unload the painful portions of that tissue so that it's not absorbing excessive stress, but it's not going to completely heal the tissue. That's still going to take several weeks to do. So if you put stress on it, it'll still bother it, whether that's palpation or overpressure with a quadrant or overpressure with a stress test of some sort. You'll still be able to elicit some sort of response, but you expect it to go down quickly enough to the point where it's just like after a few days, you can be like, yeah, daily normal motion doesn't bother it because all it's doing now, that painful tissue is only taking as much stress as it's supposed to take to go through daily activity. Once you get past that stage, then the tissue can kind of heal up. So a lot of times we'll look at the manual therapy components of our treatment protocols are just creating this window of opportunity for the painful tissue to heal properly, right? Because a lot of tissues, when people come in, they'll tell us, and Kristen, I don't know what your patient was like, but for instance, this person here, they had pain for 6 weeks, right? And it's not something that, when something that doesn't come on instantaneously, they fall on an outstretched arm and zing, there's the pain. These things, if they come on slowly, gradually over time with no particular instigating incident, it has to be micro trauma that's setting these things off, right? So we can correct that sort of stuff, take the stress off the tissue, and then we allow that tissue that window of time it needs to heal up properly. The body will take care of it. The body will do it on its own. It's our job to kind of open up that time and space for those sort of things to do it on their own, right? So, and I'm sure Dave, you probably see that same sort of thing quite a bit as well.
Exactly. Some people with the pressure valve. I mean, the dramatic ones I've seen are improve the biomechanics. A guy who couldn't serve on his elbow can now serve. And it's instantaneous because he has a normal biomechanic now and the energy gets out of the system. I've seen, ulnar neuropathy or insensitizations decrease. Where you see that, okay, it's creating increased compression. in the elbow. So I've seen that go down. Not as many as I'd like to see go down with it, but I see it.
Yeah, I mean, some manipulations work great, and it just completely removes the stress and everything. I mean, the ones that I think are probably the most likely to just dissipate immediately are the ones that have these kind of painful muscle tone issues associated with them. For instance, I just saw patients while I was late getting onto the call, came in with a 12th rib subluxation. And so it's the very obvious, like, hey, my pain is right here. They're pointing right over the quadratus lumborum area. It's very much on that flank. It's, bothersome when they twist and rotate. And so it kind of fit the profile very naturally. And basically, it was so stiff. I tried kind of messing around with it when they were laying on their side. It just wasn't going anywhere. So I flipped them onto their stomach. We did the prone technique, which I'm pretty sure I showed you guys during the thoracic course. But the manipulation was very clean and it was loud, pow, like that. And so as soon as that went and the rib is back into its normal position and able to move effectively, the quadratus muscle tone, which was the thing that was actually producing the pain for them, it just goes away just like that. It's just like, oh, the whole thing can just kind of relax. And so, seated rotation is full, everything feels great, breathing is all normal, everything's fantastic. Things like that, it's just like, this is great. When you can do that sort of thing, it's very cathartic for yourself and for patients as well. So it's a nice thing to have happen. Unfortunately, it's not always the case. Unfortunately, there are some instances where it's like, well, yeah, I have a stiff 2-3 on this side, and it's making the 2-3 on the other side very angry because of this inconsistency of being able to move both joints at the same time. So I fix one, but the other one is still kind of banging around because it's hypermobile now. Those things don't go away right away, right? So you just got to understand what you're dealing with. If you're dealing with a painful hypermobility or an adaptive tissue irritation, so for instance, wrist issues with an abducted ulna, you can't expect those things to just magically disappear. And it's easy to kind of get used to the profiles of those things when you see them a lot. When you're first learning these techniques and first learning how these things sort of react when you do these corrections, you usually you can just err on the side of caution and just say, well, yeah, let's hope that it starts to improve over the next few days. We'll check in with you again either, later this week or next week sometime, and we'll see how things feel. And hopefully at least what they'll be able to say is like, oh yeah, it's 50% better. It's 70% better, 80% better. But it's not quite all the way there yet. So it's like, well, we'll take the improvement for the first go around, and we'll see what else we need to work on. We'll see if there's other things that we need to reassess and remanipulate or remobilize, and then we can kind of go on from there. But it's a process, guys. I mean, you got to just kind of get used to how things adapt to the corrections that you're making.
Yeah, that's sort of getting into habitual movement patterns, look at what they're doing, how they're moving. Okay, what's driving this? Is there something that's
So in these instances here, the elbow and same thing with your 12th rib, you do the manipulation, you explain to them as far as soft tissue pain, and the overall healing process. You send them out with things to do as far as home, or the manipulation is the treatment, and then say, hey, let's let this tissue calm back down and let's follow up in 2-3 days, and then we'll.
Yeah, I would say you're always going to send them home with something to do. Number one, we have to, I mean, if you're doing a manipulation and you're saying this has been a joint that has been jammed up for any period of time, whether it's 4 days or it's a year and a half, and you never really know when it's those chronic issues, how long it's been there, but you have to maintain that mobility. So if your supposition is that we have a painful structure that is absorbing too much biomechanical stress because an associated structure nearby, right? So in this instance, we would have, this particular patient, it's the ulnohumeral joint that's painful, right? So we're doing a manipulation to correct that. We have to maintain movement of the ulnohumeral joint. Otherwise, things are going to go right back to the way they were. So for me, after a manipulation, after a mobilization, after some sort of treatment that I'm doing in order to improve mobility, flexibility within a joint or some sort of structure in the body, I'm always giving them something to maintain the range of motion improvements that we've found during our treatment session. And that's always priority number one for me. And for them at home is you've got to keep this thing moving. Otherwise, you're just spinning your wheels with anything else, any other exercises that we may give you. Because essentially, you're never going to get appropriate neuromuscular function around a dysfunctional joint. If you have a subluxed joint, plain and simple, it's never going to have appropriate neuromuscular function. You're going to have reflex inhibition around that joint, plain and simple. It will always be there. Same thing with a unstable joint. It's always going to have some sort of inhibitory processes because it's not stable. So you have to be able to maintain that mobility in order for the other exercise components to have the effect that you want them to, the re-education, movement re-education components, strengthening components, those sort of things. If you can't maintain that mobility, then it all falls apart anyway, right? So that's priority one for me. But then in general, yeah, we've got to give them something as well to help improve whatever the movement dysfunction was. Because if you think about it, if a patient has an abducted ulna, they're not going to be able to get into a full locked out position of the elbow, right? It's just because the ulnohumeral articulation is going to be off. So they're going to be limited toward that full locked out extension position. They're going to be limited toward the full locked out flexion position. It's just the way the body works. So those muscles that control those movements will not function in that end range very efficiently, right? So you have to give them something in order to re-educate those muscles to function in those previously non-attainable ranges of motion. I think that's probably more specific for spinal segments than it is necessarily for peripheral joints, but I do think the same thing applies in both.
Yeah.
That's the way I look at it. Dave, what do you think? What do you
Yeah,
got?
100%. It's, you be able to retrain the movement pattern. You think the first layer is, okay, movement is pain modulation. Okay, do I need them if you're moving the joint and you're getting the nerve receptors, all the input going into the nervous system, pain modulatory to one degree. Two, then you're treating, okay, what apprehension or kinesiophobia or altered movement pattern that's been adjusted to this, because they're going to move around it. So can I get them to reestablish a more normal movement pattern and variant? In the elbow, it could be looking at crossing patterns. Okay, what does their shoulder, combined wrist, elbow, shoulder, thorax movements look like? You may start local with how do I modulate pain in the tissue. Then I want to get into movement patterns. What's going on here? Are they overusing their elbow because they don't have proper thoracic or shoulder motion? So now all of a sudden they're alligator arms and they're using their elbow. Chicken or the egg. So I definitely want to go into this person is now, as I said, this is the easiest part of it, but can use movement for pain modulation, desensitization, treating the kinesiophobia, and then getting into proper movement patterns of what they're doing in their daily living. What's their meaningful task? How do I then work on that task and see, okay, do they have something aberrant in there, variable that I need to change? If they are unstable, then, okay, how do I get them to move around their instability? How do they adapt so that they're not stressing into the instability? A guy's a 40-year-old guy with this problem, but he's got a, basically unstable UCL from playing high school and college ball. How do we get him to whatever habitual pattern he's doing to not load into this potential? So yeah, no, I wouldn't stop just at the manipulation. It will be a lot of bang for your buck with it. Yeah. Definitely progress into those deeper layers.
Yep. Yeah. So if we go to David, you want to scroll down to the treatment section on here. There's some options on here for you, Chan. So we do the manipulation, we approximate the distal radius shunting, and then we start in on our re-education, right? So we're working on an eccentric pronation supination for control over ulnar position, right? So that's going to affect the anconeus in particular because of its association here with the olecranon. So in order to do that, we're going to try and do that sort of movement, pronation, supination, with some sort of weight, right? I usually have patients either grab like a baseball bat or a hammer, something that's got a little bit of top-heavy load to it as they do these things. So that's to help to maintain the movement and the articular position of the ulnohumeral joint. In some other cases, I'll have patients do what I call a hitchhiker or a reverse hitchhiker. So for the ulnohumeral components, it's basically we swing the arm up like this, and then we just try and take it into that flexion, supination, abduction position. A reverse hitchhiker would just be going in the opposite direction, bringing the thumb across the chest. That would be more of a pure mobility based maintenance of only humeral position. And then here, number 4, if we look at that, we go into some sort of weight-bearing loading because the patient was complaining about this in a loaded weight-bearing position, right? Pressing motions while working out, doing push-ups, doing things where they're down on all fours, things like that. So we're going to have them doing it very slowly, going from a, can't really see me here, but going from a extended position down to more of like a chaturanga position where they're down in this fully flexed position. And then we're just going to alter the position of their hands, right, to change position of the ulna on the humerus and the radial head on the humerus as well, right? So anything that we're doing with that, we're doing these eccentrically here because we want to increase motor unit recruitment, right? So the more motor units that turn on during any particular repetition of an exercise, the more we're getting re-educated, right? The more of the muscle we're actually working, right? And so it's an easy way to ensure that we're not just leaving out some of the components of different musculature by doing these eccentric loading things. But you want to take these things. The idea here with this is you want to take some of the meaningful task problems that the patient is having. So in their case, it was upper extremity weight bearing, so with working out or pressing motions with working out. And we can say, okay, well, how can we adapt that type of movement to help with our re-education program, right? So it shows them, number one, that we're thinking about the things that they're having problems with and that we're going to be working them back toward that return to activity, right? So if we can make things in our re-education program that start to simulate the thing that the patient wants to do, it gets them excited, right? It gets them thinking like, oh, I'm getting close here. They're getting me on my hands and, and they're putting some load on things. Like I'm getting close here, especially if things aren't hurting while they're doing it. They feel pretty good about that sort of stuff. And in general, it's going to more closely mimic the activity that they want to do anyway. So they'll be more functionally capable of handling the stress that activity will put on them by the time they're done with that component of the treatment protocol.
Thank you.
Yeah. It makes sense to you?
It does. And I guess I got lost, Dave, when you were talking about the elbow. And this is where I don't understand it is, hey, we fixed the elbow, but then we need to go potentially is it the shoulder or the thoracic spine. And I guess I'm in the mindset of, hey, I fixed the problem that the patient came in for. And
sure.
I don't look at elsewhere because I'm if it's elbow, I'm making sure the cervical spine is clear. And once the cervical spine is clear, I'm pretty much done, and feel like the elbow's back to normal.
Well, and it will depend on the patient presentation, what they come in with, right? So in a lot of cases, if there's so for instance, this particular patient, if you go back to the top of this page here, Dave, under the subjective stuff, it does mention that this patient had previous issues with the shoulder. Okay, that very last sentence there notes no prior issues with the elbow, but has had some problems with the left shoulder in the past. Okay, so that's one of those things that you have to take into consideration, right? So with overhead athletes, for instance, somebody that has to get back into this late cocking phase of movement, right? Whether they're a thrower or a racket sport athlete or any of those sort of things where they have these overhead movements, if you can't get good close packing of the shoulder, like for instance, look at my shoulder. This is as far as my arm goes back in this position. I've had torn labrums and all kinds of issues and surgeries here. And so this is as good as it gets for me. That's not even back to 90 degrees, right? So if I'm going to go out and try and say, well, I'm going to try and play baseball or I'm going to pitch a game of baseball and I'm sitting here trying to throw from here with that much shoulder girdle movement, where is the stress going to come in? It's going to go down the line somewhere. And so my elbow here now could potentially abduct as a result of loss of movement here, right? But it doesn't have to be at the glenohumeral joint. It could be AC joint issues, shoulder girdle issues. It could be an upper thoracic issue that doesn't allow good rotation of the trunk to get into that late cocking phase movement. All of those things have to be taken in consideration based off of the patient's activity, right? So if this patient came in and was just like, yeah, I'm a professional baseball player and I'm getting posterior elbow pain, but you know, the issue is it bothers me after I pitch. It's just like, well, yeah, okay, now we're going to have to take into consideration that the shoulder, glenohumeral joint, shoulder girdle, upper thoracic region could be playing a role in why the elbow has started to become painful. In this particular patient, it ends up not being an issue, right? It ended up being more from the race, the Spartan race that they ended up doing, where they had to do a lot of climbing and a bunch of scurrying on all fours, and that's what ended up creating the abduction. So sometimes you can go in and just treat the elbow and everything's great. You know, life moves on. In other situations, depending on what the patient is doing as their activity, you have to look at other potential areas as potential contributors or things that may perpetuate problems even if you fixed it. Right. So if overhead athletes, if this patient comes in, you fix up the elbow, everything's feeling good, and you're saying, okay, go ahead and get back to your normal routine, but you haven't looked into the potential for a contribution out of the shoulder girdle. They may come back in 6 weeks down the line and be like, my elbow hurts again. I don't know what I did to it. You know, so at that sort of situation, the full etiology wasn't explored yet, right? You haven't looked into these other potential contributing factors. It happens. It definitely happens a lot. I got a patient, God, the first patient I saw today has all kinds of issues going on. And I've been chasing ghosts with this person for 6 weeks already. You know, and I can get her 80% better, but then something will reoccur. So wherever the kind of keystone etiology is with this person, with this patient of mine, we haven't found it or we haven't treated it enough yet. So it's one of those things that you will run into patients like that, where they'll have an issue, you'll correct it, and then they'll come back a few weeks later saying the same thing's there. And so you have to kind of take a step back, you know, get that 30,000-foot view of it again, kind of reassess their activity level, their activities that they're involved in, things like that, and try and figure out where else could this thing be coming from. And I mean, clearing out the neck isn't a thing that you should obviously do as well, because it could be something coming out of the neck. But that's true of any upper extremity thing. You know, you should be able to look at, you know, when you do active passive resisted testing or you do your bias correction with neurological testing, looking for potential neuropathy, sensory loss, or reflex deficits or increases, then you should be able to rule those things in or out as you go through that process. That
So
makes
in my
sense?
mind, if we use you as the example with limited shoulder external rotation, and you're the patient and it's your elbow, and so am I saying this correctly? We're going to resolve the elbow pain, and we talk to the patient, educate the patient. Hey, let's get this elbow 2 or 3 days where you're pain free. We're doing some eccentric loading as far as functional activities for the elbow, but hey, we're going to have to address the shoulder and shoulder like motion if you're going to continue to pitch, because it's going to, you got to either get the motion, either your rotation in your thoracic spine, your AC joint or something, or you're going to continue to bang that elbow.
Yeah, 100%. And it'll be up to your clinical judgment to decide when to go into that. So day one, patient comes in, my priority is I gotta figure out what's going on with the elbow. Is there something locally that I need to correct? And that may be all I do on that first day. But based on the patient being an overhead athlete, at some point I'm going to say, well, we're going to have to look into the shoulder issues. You know, like for me, if I was your patient, and you asked me specifically, like, well, okay, so you're an overhead athlete. Have you ever had any other issues with that arm, you know, with that sort of with throwing? And I'd say, well, yeah, I tore my labrum when I was in college. I've had 2 surgeries on it, and you know, it's really stiff all the time. And you'd probably be like, all right, well, yeah, we're going to have to at some point look into the shoulder to see if it's potentially causing issues at the elbow. So whether it's a subjective thing or whether it's something that they bring up in particular to you, or whether it's just something that you say, okay, I'm gonna look into this because of the activity. You gotta take into consideration that there could be other body regions that are specifically affecting the painful region. And the shoulder affecting the elbow is a big one. And same thing with the elbow affecting the wrist, right? Proximal joints can very easily affect the ones distal to it, and vice versa.
the thing to remember is that you can see Eric's shoulder, but if he has pain anywhere, as he said, cervical spine, EC joint, SC joint, key spine limitation, anything that changes his movement patterning based on pain, well, it's at the elbow. His ability, he's not going to draw maybe through his forearm and his elbow to do a lift versus being able to push up because he's going to avoid a pattern. And then the most common thing to do is to go alligator arm on it and try. And now you're using the forearm or wrist to create momentum or lift where normally it would be going to the shoulder thorax, or from if it's hip and knee, if they're doing lifting and CrossFit or Spartan games. You know, now all of a sudden where they should be driving momentum through the hip and knees and they're not, they're going to pick that up in the shoulder and elbow. And then they're trying to see your elbow tendinopathy, CrossFit or something like that, for example.
Yep. I always, no, not always, but sometimes in module 6 when I'm teaching it and whatnot, and we're talking about how the shoulder can be affected on different things. I always go back and I tell this story about Peyton Manning when he was playing at the end of his career for the Broncos. And he had that 1 year where the Broncos ended up winning the Super Bowl in 2015, but Peyton Manning had the worst year of his career that year. Like couldn't throw everything. His velocity was off. You could tell the ball just wasn't coming out of his hands the same way. His accuracy was all over the place. It was just like, you know, what happened? Because this guy 2 years before that threw 55 touchdowns. It's just like, what went wrong with this guy? And why, you know, how did it fall off a cliff so quickly? And it turned out one of the guys that I play hockey with is one of the Broncos physical therapists. And so we were talking about it. And I was just like, well, did you ever look at, you know, into his upper thorax for an issue with, you know, with extensibility there, where he's having to heave into things so much more because he was having some shoulder pain, supposedly at the same time. And then he was just like, no, we never looked into that. And I was like, well, that might have been it, is he ended up with, because I remember in a game during that season, him getting hit and driven down onto that shoulder. And after that is where things kind of started to slowly deteriorate as far as being able to, you know, do the things that he wanted to be able to do throwing the ball. And it's just like, well, you know, that really could have been the problem for him, is, you know, he ended up with an upper thoracic issue, maybe an AC joint issue that was limiting the ability of the shoulder girdle and the thorax to contribute to these things. And then all of a sudden, it's, in order to get the same amount of velocity, it's, you got to really lean into it, but that takes away from accuracy, right? And so things just, you know, things just don't work as well when that sort of stuff is there. So it's definitely a possibility that you have stuff proximally affecting things distally and affecting performance as well when you think about it from that perspective. So interesting stuff. Definitely
Cool.
is.
View Jim's video on SI joint biomechanics. I'll try and put out some notes on that and some other things too, just to kind of summarize Jimmy's. Really take a look at that a bit. Eric and I will go into more in depth over time on different models, because we'll get into a little bit of applying some of the osteopathic models he talks about. And don't worry about catching up on that. I think these are worthwhile discussions to have following a course, so there's just not the drop off, and again you kind of lose this momentum. I think this is a pivot that's really time well spent. And if you agree or disagree, please let me know. I'm more than happy to take opinions, but